You're live.
Okay.
Well, go ahead, Dave.
Representative Emmons, please take over.
Welcome, folks. This is Joint Justice Oversight, and we're here December 12th. We put out some goodies here.
I think it was.
Teresa.
Yes.
Is it supposed to go around?
I didn't bring it all for myself.
Checking.
Well, it is December 12th, and we're getting ready for the holiday season. We do have some snacks. We've got a full agenda today. And the first thing we're going to start with is what was H 222, which is now Act 22. And I certainly start with the Commissioner of Corrections, I would think. We have a whole pool of folks here, but we'll start with the Commissioner on this. So welcome back, Commissioner Demo. I don't see any white hairs yet. We're having another child.
Oh, they're there. Congratulations.
That's awesome. It was different not having you here for 2 months.
Good different or bad different?
Those are only that, interpretation.
It's good to see you back.
Yes, and I'm glad to be back and glad to be back as well. So good morning, everybody. My name is Nick Demo. I'm the Commissioner of the Vermont Department of Corrections. I will also start by echoing Senator's comments. Peggy, just from the Department of Corrections, we've deeply appreciated your help over the years and really amazed at the ability to run some of these hearings and the complications, the complexity of it. So certainly, I'll miss you. I know our team will miss you and wish you the best in the next adventure. And Senator Sears, hopefully you are quickly on the road to recovery and feeling well, sir. Look forward to seeing you back very soon. So
Thank you.
we have a team here, happy to entertain any questions, talk through any facets, but I thought it might be best if we leave it open to you so that we can capture the things that you're most interested in, dive into the specific areas of either the MAT program or health and the correctional facilities in general. So we have our facilities director here. We have our head of mental health and the leader of our MAT program with us online. And then we have some other staff too that can answer questions. But excited to be back and know that this is a really important topic for you all.
So Commissioner, we looked a little bit at discussed when we were here. And I think that one of the issues that we were looking at is what's happening with discharge planning for folks who, particularly who are on MAT, and even for those who are not, but may have substance disorders. And also talking about what we might see in terms of what some of the, not deterrence, but issues that happen when you are reentering a person from an incarcerated setting, just for that transition back to the community in terms of continuity of prescriptions, what some of those issues are. And we might also get in here a little bit more discussion on the MAT program that is happening with DOC, because there's a lot of around the table here who were not present when we put in the MAT program. So it'd be helpful to have some understanding of that as well.
Yeah. So maybe I'll preface my comments by saying, the department currently has 4 key areas of priority that we want to focus on. The second of the 4 is health and wellness. And that's really ensuring that we can improve the standard of health, improve the general conditions of health among our incarcerated population and those on supervision, though we have much less control over their health. We provide the direct provision of healthcare services through a contract with a contractor. But we also know that the overall health of the individuals that we're serving is more than just whether they get a primary care visit or whether they get a specialty care visit. It's also nutrition, it's fitness, it's general wellness, And I think these are all areas where there is a lot of room for us to continue to build and expand programs that we have in place, but also design new programs and introduce them. And so as we look at the year ahead, the priority around health is going to be key to our administration and executing a strategy that really improves the overall condition of health in our system. What we know is for the population we've been serving, the last several years have been very difficult. Health as a general matter was trending pretty evenly prior to the pandemic. The pandemic had major health consequences on our population as it did with the general community. And the health situation of individuals post-pandemic has been pretty dire. I mean, folks are coming into our system much sicker than they have been in the past. Our population is aging. Correctional facilities are not therapeutic environments. I don't think that's a surprise to anybody. And those aren't excuses. That's context that we have to keep in mind as we interact with this population and try to keep them safe and healthy. And so it's our commitment to this committee, but to the broader legislature and the state, that focusing in and really delivering better health outcomes for the population is going to be a key priority of ours going forward. One of the ways we do that is through the MAT program. Nearly 60% of our population has an opioid use disorder. And that's not taking into account other types of addiction or substances that folks may be misusing. So we're talking about a vast percentage of our population needing treatment as it relates to opioids. Vermont was the second state in the country to launch a medically assisted treatment program. We're one of the nation's thought leaders on this program, and yet it's not perfect. Annie can talk about the program itself and some of the positives and the drawbacks, but there's definitely room for us to continue to improve on this. And I think it's worth remembering that the program, while it's been around for a few years now, is still ultimately in its infancy. And so there's a lot of growth and opportunity here that we can tackle.
Commissioner, what is the cost? What in your budget? How much of your budget, what's the cost of providing MAT?
Just the MAT program? Annie, I'm not sure if you have that number off the top of your head.
Hi, everybody. For the record, I'm Annie Ramnasiano, and I'm the Director of Addiction and Mental Health Unit at the Department of Corrections. So I will answer that question in two ways. There is the direct cost of the medications, which is obviously something that we track on a monthly basis and annualized as well. And that typically runs $1.25 million to $1.3 million. And that is the cost of the buprenorphine specifically. The methadone costs I don't have in my head readily available, but happy to provide that at a later date. The methadone cost was negotiated with the Vermont Department of Health and the hub and spoke system, and is either linked to the Medicare going rate or the Medicaid going rate. I just cannot remember. There is an induction cost and then a bundled cost and then a per dose cost. And again, we can get those figures for you at a later date. The methadone population has been increasing over the years since Act 176 passed. For the committee members who were around back in those prehistoric ages, we literally had maybe 5 people who were on methadone. And as the state opioid response has matured and deepened, so has the departments. And that has meant that today we have about 125 people who are on methadone and the rest on buprenorphine. The daily count today in the population was 698. Again, 123 or so on methadone, the rest on buprenorphine, and about 4 or 5 on naltrexone. The other costs are staff costs. Those costs are embedded in the contract that we currently have with WellPath. They include positions such as an addictionologist, a MAT medical doctor, a MAT program director, and then case managers that are placed at each facility. That team represents both the behavioral health approach and the medical approach to addressing this chronic illness. And again, we can compile the costs of those staff for the committee as you wish. Other costs of the program are embedded on the security side, and Travis can certainly speak to this as well. But Medlines have standards of care both in the medical side as well as on the security side. On the medical side, there is a crushing procedure and a dispensing procedure that needs to be separate from the regular medical line. That obviously takes staff, and staff time is monetized. On the security side, the same is true. There need to be officers to supervise the medication lines and also officers to support the medical staff in supervising the dispensing and the melting of the medication. Buprenorphine is absorbed sublingually, and so the tablets are crushed. The material is placed under incarcerated individuals' tongues, and they sit and they melt. And then there are mouth checks to make sure that we're reducing any opportunities for diversion. So again, we're happy to compile a more holistic a compilation of all of those costs, but that gives you a general idea beyond the cost of the medication.
So that's very helpful, Annie. And we do have a couple questions here, Jenny and then Teresa.
Thank you, Annie, and thanks for the continuing work that you're doing. And so it will be helpful to see some of this sort of spelled out, what the needs are, and then what the costs are associated with each level, and each type of need, including counseling and what currently is available. Obviously, providing the therapeutic remedy is only part of it. So if you, as we look at this, and we will look at the corrections healthcare in our committee this session in health and welfare, maybe joint with judiciary, I don't know. We'll see what Senator Sears thinks about that. But it would be very helpful to understand what WellPath is currently doing, what we are doing as a state, where our program is. I know you gave us a thumbnail of healthcare a couple of meetings ago, and I'm going to be asking you to work with DEVA to spell it out a little more thoroughly and what the state support would need to be going forward. And so the counseling piece becomes critically important, especially as we talk about folks being released from custody and from prison. So that's just a heads up. I don't have a question right now, but I just, you get it. I know you get it. So thank you.
Yeah, and a valuable issue too.
You're welcome.
Yeah.
Can I go to Senator Sears first in case he just, Dick?
Yeah, I want to echo Senator Lyons' interest, and I too would like to do some kind of joint meeting with the Health and Welfare Committee. But I'm particularly concerned. We heard at the last meeting from Tom Dalton, and there was a lot of criticism, but I think much of that criticism was directed at people that you don't have control over when they leave, and that's the detention population. And it seems as though there is obviously they go to court, they may get released, etc. What for that particular population are we doing to make sure there's as smooth a transition as possible when we don't know when they're leaving?
Yeah.
And are they eligible for the treatment?
Yes.
That's a great question,
thank you,
Senator.
Sears. Oh, sorry.
Let me just caveat one piece because I think it's important, and then Annie, I'll hand it to you. We've got this committee here, and I think we testified on this previously. One of the major challenges we face in that transition period from a facility to the community, both for the sentenced, but certainly for the detained population who then gets released, is the interruption of Medicaid. So many of the individuals that are within our system, under our supervision, detainees, many of them qualify for Medicaid, and that's their primary insurance form. when they're in the communities. Under federal law, though, when an individual is incarcerated, they are no longer eligible for Medicaid. And so their Medicaid stops. The federal law also precludes us and any other correctional entity from helping to enroll, preparing that transition to the community until they're released. And the state of Vermont has no control over that. There are efforts afoot at the federal level to change that law. And there's a couple of different ways, then we'd be happy to come into your committees and testify about that. But to at least expand eligibility for Medicaid 30 days prior to release, that seems to be the primary effort that is gaining some traction. That would enable us to much better case plan for folks transitioning back into the communities. But I think the Medicaid funding piece of this and the prohibitions on states from really enrolling and helping people with that transition of service, it is a huge hamstring to us.
So Commissioner, when you say the state is prohibited, is that DOC specific or is it the state as a whole? So Department of Health or DEVA couldn't do it?
Nobody can do it with an individual who's incarcerated. That's the language within the law, is, you know, mid-century effort to manage that population differently than the general population. And so there is a high interest by the state, both DEVA, the state's Medicaid agency, and also the Department of Corrections, to do that work. We would happily engage in that, but we're precluded under federal law.
My understanding was that some states have received waivers.
That's right, Senator. So that's the other major effort afoot. California was the first state to receive a waiver. That happened about 3 months ago, give or take. And the state of Vermont has been in talks with the Centers for Medicaid, Medicare about the 1115 waiver process. And we're advised that we should wait until California's waiver was approved and then use that as the model going forward. So that work is underway, and certainly that's something that we're interested in seeking. That is another opportunity for us to try to expand some of this eligibility, but that process is only just getting started across the country.
Thank you.
Another question, Teresa?
Thank you. So I understand and have understood the issue around, recipient can't be a recipient of Medicaid while they're in a correctional facility. Is there anything that prohibits during the discharge planning process from you assisting the individual to apply for Medicaid?
Yeah, so they can't enroll until they're released.
I understand about the enroll part,
Yeah.
but there's an application process.
Mhm.
And do you assist the individuals to apply for Medicaid so that on day one of their discharge, they could be enrolled?
I think the answer is generally yes. I mean, I look to Annie on the discharge process, but it's a fine line between, kind of handing them the papers. Obviously, that is something that could easily be done versus the actual taking the steps to connect with a primary care provider, the enrollment piece, which we're prevented from helping them with until they're actually.
I would love to see the language on that, if you could provide us the language on that, because it doesn't make sense to me that you can't assist somebody to apply for a benefit. I understand not receiving a benefit until they're discharged. So if we could get a copy of that,
Yeah,
language, people have it.
One of the major challenges, I mean, obviously preventing them from enrolling prior to release is the first of a series of challenges. But I think one of the other primary challenges is even if we help them get everything in order and the first day they step out of the facility, they file it, the connecting to primary care physicians, connecting to medical providers in the community often doesn't start until they have the enrollment. And so it still creates a gap, even if we try to tighten that up as much as we can. But I think it could be valuable if Annie could explain the discharge process and what we are doing to help people, kind of preloading prescriptions, that type of thing. Because that is some of the way we can bridge this, but it's still, even if we do everything perfectly, there's still, unfortunately, this kind of air gap between the two.
So let's go to a few more questions and then we can have.
Okay, I had one more.
Okay. And then we can go into the real discharge panel.
Okay, sure.
I know we got some folks with some
Okay.
questions.
So my other one is a follow-up to testimony we heard at our last meeting. And one of the things that that was testified to is that there is a withholding of MAT as a consequence for certain behaviors of the individual. And I'm just, I don't know if it's you or if it's Annie or somebody else, if, and maybe it's Stephanie, I see she joined us here, can respond more completely with that. It seemed to be a consequence, withholding medication seemed to be a consequence for certain behaviors. And I understand that, people feel there's some rationale for some of those things. But I would love it if one of the three of you can elaborate more on that.
Yeah, so, it looks like Stephanie wants to weigh in.
Sorry, yes, I'd like to introduce myself. So I'm Dr. Stephanie Ruckman. I'm the Vice President of MAT Operations for WellPath. So I oversee our MAT programs across the country in over 27 states. So I'm very excited to get to speak with you guys. I've actually been and visited all of the locations after we took over the healthcare in Vermont, and we're very excited to be there. And as someone who eats, lives, and breathes MAT, I was very excited to get to be a part of the history of the Vermont program. I cannot speak for other healthcare vendors, but I can tell you that WellPath does not believe in withholding or decreasing medication for punitive reasons. That is not our philosophy in any way. We do know, though, as a healthcare vendor coming in, we do have to provide a lot of education and training for our staff on our philosophies. And so that's one of the ongoing things we are continuing to do. We also do CQI studies on our patient care to ensure that we are following our goals. So I'm very confident in saying that is not our philosophy and that is not how we want things done.
Thanks, Stephanie. I will add from the corrections side, since the program started, we've had about 19% of unique individuals be discontinued at some point. Of the discontinuations, 70% of those have been for diversion. So not taking the medication or trying to pass the medication to other individuals or stockpile medication. And that the medical providers can speak to the risks that are involved in diversion if it's passed to somebody who's not prescribed or if somebody stockpiles and takes a bunch at once. The other 22% are patient requested discontinuations. So, well over 90% of the discontinuations that have happened since the inception of the program to today are either because of diversion or a request of the patient. And then there's a few other little ones, but the smaller categories are not punitive discipline. It's tapering, medical necessity, those types of.
So I get the people, requesting not to be a diversion. I think, we don't probably have time to dig into that one
Sure.
as much as I would like to here today, but that I would still be interested to understand what efforts are made to, as Dr. Ruckman just spoke of, educating the individual and reinstating their MAT. I would be more interested in that, but I'll let.
Yeah, and I think just to end that part of the conversation, I think diversion is one of the primary complexities of the MAT program and something that there's a security imperative that we're weighing, there's medical imperatives, and there's just, what do we want our policy to be that fits within, the appropriate medical advice. And I think that is worth further conversation and discussing that to make sure that the state is aligned to its values, that we're doing that right. But knowing that there is more to it than, stopping somebody. The goal is not ultimately to stop somebody from getting medication. There are other things happening there, but I think that is worth a longer conversation. Absolutely.
But who has the final say? Because the law is written that it's the medical provider on a medical decision that makes that decision.
That's correct.
To start someone on MAT. So if there's a security breach or there's diversion, who ultimately makes that decision to take the person on?
That's
Is it WellPAC?
So the medical provider who's treating the patient is the ultimate decision maker. A staff member who observes diversion may advise the medical team that that is occurring or what they saw, but ultimately the decision rests with the medical provider.
We have some questions here.
Mhm.
We have Ginny Topper. Topper, you had your hand up. Do you still want to after Ginny? And then we'll,
Yes, I
Okay.
do.
okay, so we'll go to Ginny first, and then you Topper, and then Keisha.
Okay.
So I'm gonna make a comment, I may ask a question, but I'm going back to the dark ages, who's the prehistoric ages? We're not that over there. But when we began the MAT program, and I was very much involved with others here in that process. And we talked a great deal about the disconnect between corrections and healthcare and how can we bring those together. We brought folks together, we had a discussion. I feel like we're almost in the same place. I think the MAT has progressed very well.
Yeah.
Corrections has done a good job with that. However, I feel there's a great level of frustration here that we haven't improved the healthcare outcomes for folks who are incarcerated. Now, the question I have, and I will ask in committee, probably don't need to answer it today, is there a separation we need to make between corrections and healthcare and allow for healthcare to be in charge of healthcare and allow for corrections to be in charge of security? That's a big problem. We know there needs to be education. Perhaps there needs to be additional staffing. Because I don't know whether the staffing has changed since all of this went in place. And obviously, we see this elevated need for methadone, for buprenorphine, for counseling, for our corrections officers to be engaged with this. So those are questions that I have, and they will not end. I'm very concerned. I am very concerned about the high cost of healthcare in the state of Vermont. We are one of the highest cost healthcare corrections programs in the country, and we've been that way now for a while.
Yeah.
So I want to see the bang for the buck.
Yeah.
Yeah, so I haven't seen it. And I'm not degrading what has happened. I'm looking at Annie. I know the fabulous things have happened, but we don't know when people are leaving. We don't know when the 30 days begins. I mean, you're reflecting what Senator Sears has said. We don't know those little tiny things. I keep hearing the same thing over and over again. They're not eligible for Medicaid. You can't help them apply. Well, let's get this done. I'm sorry, so I'm venting a little bit. But it would be great to hear some response as we get further into this during the session, because we don't want to keep doing the same thing over again. And you know what?
Yeah.
Okay, so that's all. I see you're agreeing with me, so.
Yeah, no, I mean.
Hopefully we'll make some progress on this.
I think you're keying in on the right questions around, who actually makes decisions. Where is the bang for the buck? How are we getting what we're paying for? So I won't answer all those right now. I mean, I think that's a deep conversation that we can have in committee. What I will say though is I share your frustration about this. I agree that I don't think materially healthcare in the correction system has improved much. I have just passed my 2-year anniversary. And I think we made some improvements. I think we made some strides, but definitely not in a material way. I'm not seeing huge changes that should be lauded or celebrated here. And in looking back prior to my time here, I think that's a continuation of the storyline, as you said. So I'm optimistic that the new health vendor with Vermont's kind of commitment to get to the community standard of care will improve. But I also think while it's been a a line of effort. It maybe hasn't been the priority that it should have been. And so that's why we're making those adjustments now, and hopefully with a new vendor in place, we can make some strides. But certainly, I think you're asking the right questions, and I just want to express that I share the frustration on that front.
So let's go to Topper and then Kate.
Yeah, as we keep talking about it, my frustration or the question that I was going to ask is being answered, but it's not completely answered yet. I really feel that our committee, when we get back in there and we take this up, we really need to know what how the transition plan is developed and kind of what goes on when that person moves from the oversight of the corrections department to everyday life. I think that's important, that there's a transition plan that's spelled out, that maybe WellPath leads the way for them in the community, so that they're set up when they leave. Because that's when if they're not, that's where the problem is going to develop again. So that's what I will be asking that question, I know, on our committee. Thank you.
Valid. That's real valid. Keisha?
I just wanted to know what the likelihood is of a diversion with the crushed sublingual medication. Just educate me. And also, when the health risks of diversion outweigh the health risks of withholding medication.
Good questions. I think I'll turn to Annie to talk to the first question, and then maybe Dr. Ruckman to talk to the second one. I think you'd rather hear from the experts on these 2 points.
Hi, so in regard to the first question, this is something that I monitor on a weekly basis. I get a report from the vendor, WellPath, who has voluntarily elected to be tapered from the medication, as well as who has been tapered as a result of diversion. As was already stated by the commissioner, this is solely a medical decision, and we typically see a pattern which is aligned with the guidelines that the contractor is required to follow, that after the third diversion, depending on the severity and the context of each of these incidences, that a very strong multidisciplinary team decision is made, evaluated from all sides. As I mentioned in the staffing matrix, there are MAT case managers that are having contact with people right after the diversion occurs. The individual is receiving counseling. They're receiving what's called cost-benefit analysis, helping them evaluate the antecedents to their decisions and their behaviors, the consequences, what their thoughts and feelings were around that, trying to develop a mitigation plan, a support plan. There are open ears coaches in every facility who are also available to provide support to individuals. The individual can also put in a sick slip for individual coaching. There is an app on their tablet that also offers tremendous support regarding this area and others around addiction and mental health. So we've tried to build an array of services to help the person cope with the cravings that they're probably having and the other behaviors that are associated with addiction. So it's within that whole context that the provider will have to look at all the information about the diversion and make a medical decision. And that goes to the second part of the question. When is the decision made to taper or change somebody's medication? And the different components that go into that, which include assessments. There's a specific assessment called COWS, the Clinical Opioid Withdrawal Scale, that will probably be used by a provider, and other tools. And I will kick that over to Dr. Ruckman.
Annie just explained that very beautifully. So if someone does have to be taken off of their medication, it is after many, many, many attempts have been made to get the patient engaged in their treatment as we hoped they would. Even if a patient, though, is ultimately found, if it's found to be in the best interest of the patient to take them off the treatment at that time, our goal is always to talk to them again prior to their release, just to give them one more opportunity to start back on that treatment, since we know after they're released, that's the highest risk of overdose possibility. So once again, even if someone does ultimately have to be tapered off their medication, we're offering alternatives, we're keeping them engaged with mental health, and we're re-offering treatment again before they leave. But in some situations, unfortunately, the patient may become a safety risk if they're giving their medications to people who don't need to be on the medication. And so that would be the ultimate reason that we might have to make that decision. But we do not take it lightly, and we want it to be rare, not the norm.
Can someone tell me how they physically divert medication that in the process that you outlined?
Yeah, if the process is followed like we want it to be followed, it is very difficult. Not to be graphic, but I mean, we've had situations where we have had people, hate to be graphic to non-medical people, but I mean, they'll insert a tampon in the back of their throat, or when they swallow the methadone's absorbed in the tampon, they can later regurgitate it and share it with another inmate. We've had individuals who the powder, if it's not allowed to dissolve over the appropriate amount of time, they'll pack it in openings in their teeth and cracks and holes, because unfortunately our patients a lot of times don't have, they've not received the best dental health care over their lifetimes. So that is a way that they can kind of squirrel it away, store it away, and then when they get back to their cells, swish, spit it out in a cup and share it with another inmate. So folks can be very creative, so we've seen a little bit of everything. But that's why one of the first things that we do if diversion occurs is we are looking at our process very heavily. Was there something that we could have done to have prevented the diversion? Did we have the officer present? Did we follow our own policies and procedures? So that there are ways, but very difficult if we do our job properly.
Thank you.
May I add also that, COVID was a very difficult time, as Commissioner Dummel pointed out earlier, in terms of delivering healthcare for a variety of reasons. One reason that healthcare, and specifically this program and the diversion issue, really was impacted by COVID is that when individuals were wearing masks in the facilities, those masks also provided a vehicle for diversion. People simply spit the solution into the mask and then would dry that and scrape it off and reclaim it. In addition to tampons, the one I see most frequently in Vermont is a pen cap that they are able to dangle in the back of their throat to capture the saliva from the dissolving. There are many, many different ways to divert the medication, unfortunately.
Welcome to the world of correction.
Yeah, we don't work that with stuff.
There's a lot of nuances. I know that we have with us also the Deputy Commissioner from the Department of Health. I don't know if this would be a good time to transition to that. We don't want to let you go either, Commissioner Corrections.
Of course not.
But Deputy Commissioner Doherty, welcome. You've heard some of the thread of our conversation and questions, and I just want to give you an opportunity to weigh in.
Sure. For the record, my name is Kelly Doherty. I'm Deputy Commissioner at the Department of Health. And I would just, with respect to the continuity of care for folks who are leaving corrections, who are on MOUD, we work really closely with the Department of Corrections. Our staff in DSU meet with Annie regularly to make sure that we're connected and that we're doing the appropriate planning. Like was stated before, I think it was Senator Sears, where things get tricky is with the detained population. because it's so unpredictable when they're going to be released. So, it's hard to do that medication planning when sometimes people are just released instantaneously after the judge orders it. If somebody was on medication when they came in and were detained, then they would simply go back to the provider that they had in the community. But if they are newly started, then DOC will help try to connect them to the closest hub in their area. The hubs are experienced working with folks who have just come out of corrections, or they're given a phone number for to get the bridge prescription. So, but sometimes getting to the hub can be complicated for folks depending where they are geographically. Also, it was touched on the insurance issue. So if they came into the facility without having health insurance and they leave without health insurance, it makes it challenging, particularly for the spokes to serve them right away because they have to connect them to getting insurance. So at the hubs, we have funding that we can use to serve people who are uninsured. But when we're talking about the office-based opioid treatment providers, that can just be another hurdle to get through. But like I said, VDH and DOC are very much in partnership on this. And, I think that we've come a long way. About 70% of people who are coming out of corrections are following up with their MOUD within 45 days. Sometimes the path is a little circuitous, people engage and disengage in treatment all the time, but I think that we're doing our best in partnership with DOC to ensure that those connections are made. And Annie, I'll see if you have anything you want to add to what I said.
No, thank you so much, Kelly. I would just add for the committee that the work that Kelly's talking about of continuity of care was another collaboration that the department had with DEVA. And the longitudinal study that she's citing is on our website so that you can see that in all of its glory. And then a few other details, our provider, whether it was our previous contract or our current contract or WellPath, part of the contract responsibilities requirements are to provide a bridge prescription upon release. And so that bridge prescription is actually paid for by the department. That's part of the medication costs I gave earlier. So the prescription is called into a pharmacy of the individual's choosing. WellPath is paying for that prescription, and that is the bridge to the community-based appointment that Kelly is talking about. That's where the insurance piece really comes into play. Along with that bridge prescription contract requirement, it's also the contract requirement that the vendor turns on their Medicaid prior to release. So for somebody who does not need to fully enroll, that is the responsibility of WellPath. This is a huge part of the discharge planning. But I want to make it clear that the bridge prescriptions for both MAT, psychiatric, other essential medications for healthcare, those are all the contractor's responsibility to make sure those orders are called into the pharmacy, and WellPath is covering the initial bridge prescription into the community. The other really tricky thing to highlight all of these different layers is, as has been mentioned, we know when a sentenced individual is being released, and we expect 100% discharge planning success for those individuals because the release is known. Unfortunately, as you've heard already, between 30 to 35% on any average day, those for the rest of the individuals are detainers. And as Kelly said, they're released from court. We have tried to examine this in so many different ways at the department. How long is the notice from the sheriff to the facility that the person is going to be taken to court? Is there any wiggle room there to get a discharge packet developed? I've talked with at the secretary level with Willa Farrell with pretrial services and to see whether or not there was any community-based connection with the monitors who were also going into the court. The department is open for any collaboration in any of these areas to improve the release planning of people who are detained. but we simply don't know when that's going to happen. And it is extremely hard to get information into their hands. A few other efforts you should know about is we've published on the tablets phone numbers that they can also call to get reconnected to providers at the facility so that the prescriptions can be called in post their release. And we've also discussed and we've also put up posters at the edge of at the entrances of the facilities. And then if somebody does get a discharge packet, we've developed 2 positions with WellPath that are regional discharge planners who have centralized phone numbers. But again, the rub is that somebody would have to get this piece of paper before they were released to be able to call it. And then we've cleaned up as much as we can all of the phone numbers and the phone trees. I've literally done a walkthrough of all of the phone numbers to try to make sure that the phones work and that when people call numbers and press 1 for medical, that actually goes to somebody who identifies themselves and who can actually help. So it's just a complicated system. And there are so many opportunities, as we all know, especially for the detainers, to fall through the cracks. And we're working as hard as we can and looking for help from anybody to help us solve this riddle of how do we make sure people get what they need when they leave our doors.
So I just can't help but process this. We got 2 different populations. We've got the detainee population that may need different avenues and support than the sentenced folks for reentry. Yeah, some of it may overlap, but some of it may be so distinct and different. And I'm thinking, yes, you've posted all this information, yes, on the app, on your iPad, they have all these phone numbers, and I'm just thinking what it would feel like to be a detainee, that you're arrested and then you're housed in a correctional facility for 3 days, 4 days, maybe a week. I don't think your mind is focusing on a phone number or a piece of paper to follow up. We would in our life, our regular life, because we're not incarcerated. That resonates with us. If you're incarcerated, I think you got a few other issues going on that you're more focused with than trying to make a phone call. So that's one piece on the detainee side. On the
Representative,
Yeah.
can I just comment on that? I mean, I think Dr. Ruckman did a nice job of reminding us that none of this is clean. Like, it's not, we sit here and in the department too, we talk about systems and processes and how somebody enters and moves through the steps and then is ready for release. Here's what's really happening. An individual who has an opioid use disorder presents to our system. They've been arrested on a Friday night. They're brought in by the sheriff or the state police. Oftentimes, they have multiple substances in their system at the same time because our drug supply in Vermont right now is extraordinarily dangerous and extraordinarily complex. They present with severe withdrawal and detox symptoms. And so often those first few days are just stabilizing and protecting the individual. There is not time to talk about case planning and making sure we connect you with the right MOUD treatment provider in the community. We're simply trying to keep you alive for the weekend. And then on Monday morning, they present to a court and are released and they're gone. And we no longer have any control of them. And that's rightfully so. In many cases, they should be in the community. But this is a messy, complicated problem with a drug supply that I don't think we really understand yet. That's evolving very quickly, presenting with new drugs that we don't have treatments for. And so when we talk about the detainee population being so complicated, they present with very complicated issues. We don't know how long they're going to be with us often. Often they're with us for a very short period of time, a matter of days. And then they are immediately moved back to the community. Some detainees who are charged often with more serious crimes or violent crimes stay with us for longer. And they can begin to resemble a sentenced individual in so much as we know they're going to be held without bail for a long period of time. We have time with them. But to give you some context, nearly 40% of our system are detainees. So we're talking about nearly half of the people we're serving fall into this very complicated category where we don't have a lot of control about how long they're with us or when. We don't necessarily have any background on their medical history, their substance use history. We go through much of that in the intake process. But again, if somebody's presenting with severe detox in the first day, the intake process questions aren't going to give you a lot of clarity. And so I think it is worth capturing that context and pausing to remember this isn't just individual presents on day one. By day two, we hope they're in these 3 steps. And by day 3, we've got them enrolled in the MAT program, and then we're off to the races. That is not typically how it happens.
So then the other piece is the sentenced person. And some of the work that the Corrections and Institutions Committee has done over the years, in terms of the medical piece, it's very clear in testimony we've received that quite often when someone becomes incarcerated, they are not hooked up with a primary care provider in the community to begin with. And they have not accessed healthcare for a long period of time, if ever. So then they're incarcerated for a year, 5 years. There's a whole dynamic there of trying to hook them up with a primary care provider that they had before. Who is responsible in DOC to help that person hook up with a provider? Is it WellPath or is it internal staff of DOC?
Yeah, so there's the discharge planning that happens, and there's the casework that happens in the facilities. And there's both medical work on that front and our correctional staff helping people prepare for release and connecting them with the right probation parole office if they're going to be on supervision, which most sentenced individuals do typically go out under supervision. Annie, I think, can talk to the discharge planning that happens, but I think she highlighted to you all, for sentenced individuals, we have a much greater likelihood of success in planning out what that exit looks like because we can predict when they're going to be released. And for the detainee population, we often just don't have the time to do that. But Annie, I don't know if you can speak to discharge planning itself and who's connecting with the right folks.
Certainly. So as the commissioner just stated, it is a conjoint effort with the sentenced individuals because we know the time frame that they're going to release. The release planning starts to happen both on the internal facility casework side, connecting in a multidisciplinary team with the field office as well, to make sure that appointments are going to be synced up against the context of their ongoing supervision, where they're allowed to go, where they're not allowed to go, et cetera. And then the medical staff does their piece as well. Medical will take care of activating insurance. Medical will take care of reviewing the active problem list, the active medical needs of that individual, and then from that list, developing the discharge plan, the current and active medications, identifying with the individual what pharmacy they would like those medications, the prescriptions to be called into, and then also connecting them with primary care and any other ongoing specialty care that they may be receiving, to help people orient to the way healthcare is delivered. If you need specialty care as an incarcerated person in Vermont, we use the public system. So that individual will be referred to UVM, to whoever, just in the community, ear, nose, throat, pulmonology, et cetera, and they will go to that regular physician for that specialty care. They also access our hospital system because we do not have a forensic system of healthcare. So all of those active problems will be reviewed by the medical director at each facility, and that will inform the discharge plan. But again, as the commissioner and others and myself have stated, that has the best opportunity for success with a high percentage of compliance in a CQI process when we know the release plan. When we know the release date. When we don't know that date, we try to plan as much as possible, and I've been directly involved in building these workflows We plan for discharge at release. The initial health receiving screen has also been reviewed by Dr. Levine. We gather the most comprehensive amount of information that we possibly can. It is also dependent on the person's ability to comply. Sometimes they don't want to comply, and it takes quite a while to get that information. And then we are informing them about, especially if they're a detainer, that they could be released at any time, and we're trying to prepare them for that. So again, Representative Emmons, I agree with you. It is very difficult when somebody's in that level of turmoil to absorb a phone number or any of this information. But all we can do is be patient, to have clear and direct communication, and to try to impart to people the information that is necessary for them to know, and to try to activate their own self-agency to be a partner in that process.
So I know we got a question, but I just, so for a sentenced person for reentry, and it's up to the healthcare provider, WellPAC, to hook them up with insurance, to hook them up with the primary care provider. When that person is released, is there an actual appointment date that they have with a provider? Or is it just a referral, which then means the person needs to set up the appointment?
The contract expectation is very clear, and the expectation is an appointment. If there is an active problem that needs to be followed up post-release, there is an appointment made. So again, Dr. Ruckman touched on this, but we have multiple layers through all of our workflows for different CQI processes, including it's continuous quality improvement. I'm so sorry. So we look at large metrics. We're always looking at every level of the system, from the individual patient experience that gets audited or brought to our attention by somebody like Tom. Tom and I email every day. I'm looking at cases and investigating cases when they come to me, from public defenders, from Tom, from other advocates, from anybody, from mothers. And then I'm also looking, along with the rest of the Health Services Division team, at monthly and weekly reports that are all required by the contract. And we're looking at all of the trends and compliance with the benchmark that we've set, which typically is between 80 and 100% compliance. So it's a huge meta-analysis of data, but then it all goes back down to the patient experience and looking at the patients as well. If we're looking at trends, we'll then also isolate those trends. We'll have other reports run, and that will give us a list of names, and we literally will go in and decide, like a randomized sample, that we'll choose every fifth name. And as a team, we will go in and look at all those medical records to make sure that we understand what's going on, and or catch things that are less than optimal, and then bring that back to the table for a plan, do, study, act remediation plan to improve the metric and individual patient experience.
We have more questions here. Martin and then Jenny.
Yeah, just with respect to the detention population, individuals who are being held without bail, are they treated somewhat differently since they're likely going to be there for a while, given how long it's taken to get cases through the courts?
So, I mean, ideally, everybody is treated the same, but there are interruptions in service, basically, I think is the way to think about it. So if an individual comes in, they're arrested but not arraigned, it's Friday, whatever, court is on Monday morning, and they're released, we can do as much as we can in the period we have them. For individuals that we know are with us for a long time, I mean, the intake process is the same. So they would go through that same intake process. Housing is not really based on your detention status. It's based on risk and some other factors. So that isn't really impacted whether they're with us for a long time or a short time. And so the experience of an individual in our system, whether they're detained or sentenced, really there shouldn't be too much of a difference unless they're an individual who's leaving very quickly. I don't know if that answers your question exactly, but.
So, and do you know who are in those statuses? I mean, the individuals that are likely going to be there for shorter than a couple of weeks, Is that not always?
We know once they've had their initial court appearances,
Right.
typically how long, whether it's a hold without bail or it's a hold with a very high bail that the individual, won't be able to post. Yeah, I mean, I think we can make very good educated guesses about who's going to be with us for a long time or not. And then it's dependent on the court process, how long it takes them to go through their adjudication.
Thank you.
So Annie wants to weigh in on this.
Yeah, so I just want to enhance the commissioner's answer with this perspective. There is a timeline. There are standards of health care that we comply with. And there is a specific timeline. And this is, again, another area of continuous quality improvement. But within 24 hours by statute and also by these healthcare standards, we must complete an initial healthcare receiving screen. Then within 7 days, we must complete a full health assessment. Within 14 days, we must complete a full mental health and substance use assessment. By the end of that time period, it's required that we have a comprehensive conceptualization of that person's healthcare needs. The other things that can interrupt that are lack of compliance or medical issues that are interfering with the person's ability to reply and comply. Other issues that might extend that timeline could be related to translation needs. We have many different languages spoken inside of the facilities as well, so it may take time to be culturally sensitive and to find a translator that is trusted by the individual so that they can fully participate and give their own informed consent. And then aside from the sentenced and the detained populations, I just would like to remind the committee that we have another group of people, and Kelly certainly knows this well, called in-caps. And any given year, we have between 1,000 and 1,500 unique individuals who primarily are housed at Chittenden and also at Northwest, who come in literally no more than 24 hours. They're in protective custody. They're not charged, but they also are provided the same initial healthcare screening and their health needs are addressed. The next population, which is different and primarily at Northwest, are federal detainees. These individuals are in the U.S. Marshal custody, and we actually need to get permission from the U.S. Marshals federal system to provide any other specialty health care. So this often comes up in grievances that the feds have decided that that person's does not have a right to access that medical care, and we have to comply with their order.
Welcome to the world of corrections. It's like an onion. You just keep peeling off the layers.
Yeah, thank you. And thank you for elaborating on the process and procedures earlier with regard to folks who are being discharged or folks who are coming in and how they're handled. And going to the last comment you made, and then I'll have a question about your earlier conversation. That if it's the judiciary can issue a request for a competency hearing that can come from either federal court or state court. So that would have to be followed. So any court order would need to be followed within this context. So that is helpful. The question that I have about your earlier comments and description is, do you have, I've read the MAT rules. So the rules have come to LCAR and we've looked through that. But are there other rules that we have related to evaluation and discharge? Some of it's in statute, understood. But do we have any rules and procedures that are, or guidelines that are consistent between the contract with WellPath and then with what DOC is doing? So do we have those documents so that we can look at them?
We do have the contract.
Oh, no, we've seen the contract.
Yeah, so
But in terms of the relationship between Department of Health and DOC and the contracted provider? Do we have a set of rules and guidelines that are available to folks who are either involved in corrections or judiciary or, people like us who, boots on the ground? We just want to understand a little bit the process that's going on. So do we have that?
Yeah, so beyond the state laws that control on these topics, we also have department policy that would discuss some of this, and that's all publicly available on our website. But we can certainly share it directly with you all as well.
Well, it would be helpful and to understand if there's a step-by-step guidelines that are followed. I understand it's all embedded in Annie's mind and in yours. I mean, it's great to hear. There's no question about it. But it would be extremely helpful to be able to put look at it.
Yeah, these are outlined in our policy and procedures, and certainly we do share those with you.
Okay,
And then the relationship between the department and its vendor is outlined in the contract, which.
Right, and then DOH and DOC, do we have those relationships spelled out?
That's a good question. Annie or Commissioner?
I mean, one of the things that I continue to think about, and we will be talking about in our committee going forward, is in health and welfare, is Department of Mental Health and how that department influences decisions being made in other departments and agencies. So, yeah, okay.
Yep, so Senator Lyons, I'm not sure, I don't think you were part of the previous testimony and legislative report that we filed, but part of Act 176 requirements was to file an evaluation. And so that was done in partnership with UVM. And then subsequent to that process, we were also asked to conduct a national peer review on the clinical guidelines around our MAT program. And so that was filed as a report, and I'm happy to make that available to the committee a number of years ago. And the group that provided a peer review included some of the preeminent people in this space here in Vermont and as well as across the nation. Dr. Brooklyn was one of those reviewers. So the MAT clinical guidelines and policy and procedure that are healthcare related, not DOC security related, are actually included as part of the contract. They're one of the appendices that any contractor who bids in Vermont has to attest to that they will comply with in full, unless there is conjoint agreement that medical science has advanced to the area in some way, and then the department would agree with the modification of that policy and procedure. But otherwise, the contractor is required to adhere to what is in the appendix of the contract.
All right, thank you.
So we have another question, and then I want to move on to Steve Howard, because he's here to talk about some of the testimony we received last couple of weeks ago when Tom Dalton testified before us.
I wanted to ask Dr. Ruckman, while we have her, in your experience with 27 states, is there anything unique that you want to emphasize to us as a challenge or opportunity for Vermont, something you see that you want to uplift or a deficit that we should be looking at?
Honestly, think you've identified it in these discussions. Vermont is unique in that it has the detainees and the sentenced population all under one roof. I honestly cannot think of any other state system that we have that operates that way. Usually the county jails have the detainees and they're in and out very quickly. And then your state systems are more your sentenced population that are going to be there for a while. So I do think it is a unique challenge to Vermont that we don't have in other states. But I think everything that we're doing in those county jails for these folks is being done in the Vermont DOC. I think it's just one of the realities of the challenges that we face with this patient population. But overall, I mean, the program is wonderful. All of the legislation that was put in place to support this program is better than anything I've seen in any other state. I know Annie and her team have worked very hard, and that's very evident with what we walked into and what we have seen so far in Vermont. So once again, we're just very proud to be a part and be a partner in seeing this be successful. But I think that challenge is what makes Vermont extra extra special.
Special or? Very
Or
special or?
I'm in the South. That's what we say. That's how we phrase it.
That's true. It's a different connotation.
So we're going to be doing deeper dives in this in both bodies, the House and the Senate, come January. I'm sure we'll be having you back, Dr. Ruckman, as well as our Deputy Commissioner from Department of Health, DOC, maybe Department of Mental Health, because we are going to be doing a deeper dive into the healthcare system. And I'm intrigued by what Senator Lyons put out in terms of, and to be thinking about this, should DOC only be concerned about the security end? And should the Department of Health be more concerned about the providing of healthcare services within DOC? Then how do we meld those two together? Because there's some different dynamics there. So I'd like to transition now to our state employees. Steve Howard is with us on Zoom. And I know that they wanted to weigh in because in our testimony at our last meeting, Tom Dalton referred to some of our correctional staff, and I know BSCA wants to weigh in on this. So Steve, welcome.
Thank you, Madam Chair, and thank you, members of the committee. I do want to just apologize in advance. My very vocal dogs have just decided that they need to protect me from the squirrels on my back porch. So if you hear them, I apologize. They've been quiet all morning, but now, of course, they're up and moving. So if you hear them, that's what's going on. For the record, I'm Steve Howard. I'm the Executive Director of the Vermont State Employees Association, and I really appreciate this opportunity to share with the committee. There they go. Share with the committee the perspective of our correctional officers who bring a real-world experience to the table on the issue of the MAT program and all that is happening in our facilities. I want to start by just reframing. Hey, Tilly, you just said. Sorry.
I'm used to cats. I'm not used to dogs, but I'm used to cats walking in front of you.
She's usually pretty good. I don't know what's going on today, but I just want to reframe for the committee. Our members did listen to the testimony that was offered at your previous meeting, and they asked me, and I really am just the messenger. They are the frontline experts on the work that they do. They wanted me to remind the committee and those who are listening that their expertise is in the security of the facility. They were hired and trained and have ongoing training on how to keep the facility secure. And that is their primary role. They asked that I convey that we not forget that there is substantial risk of harm to both other inmates in the facilities and to other staff if they are not able to or somehow hindered in their ability to monitor the facility and to keep and to use their expertise to keep the facility safe. I have, in my experience of the last 12 years of working with them, have found that they really could educate us all on what it really takes to keep a facility and a community safe when it comes to folks who are incarcerated or who are being supervised in the community. On the MAT program, they do have a great deal of concern about the program. Incidentally, they also wanted me to make sure that I reminded the committee that, as you heard today, that they don't make the medical decisions for the medical staff. And they often take the hit, as they would say, or the blame for what happens when medical staff makes a decision that doesn't end up going the way people had hoped. But they are concerned about this program for a variety of reasons. They do see widespread diversion, and that does have impacts throughout the entire facility and throughout the entire system. that they have concerns about. They are there to prevent that diversion to the greatest extent possible, and to protect the staff that are administering the medication to the inmates. I think one of their frustrations, really, the term that was used in the last meeting is that the union and the members of the union had expressed frustration with the MAT program. And they do feel frustrated. They are frustrated by the lack of staff, the lack of resources to prevent further diversion. They were frustrated at the outset of the program and still remain so, related to the lack of consultation and feedback to folks who may be in offices in Waterbury and are outside of the facility, but aren't there every day, who don't know these inmates as well as they do, and who aren't, really, frankly, in the line of fire should something go wrong in the facility. And so they really wanted me to convey that. They also really took great offense at the concept that they would punish people for unrelated disciplinary issues and withhold medical services to those people. And they really asked that the committee not give much credence to anecdotal evidence that's provided to you, where that evidence came from and from whom, and the credibility of that person is really unknown. But also it's just really hard to prove. And it's disparaging and bothersome to them that anybody would accuse them of that. So they asked me as their spokesperson to correct that and honestly try to encourage the committee not to really give that much credibility. In general, on the MAT program, they had some things to offer. I mean, they basically, generally, the folks who shared what their thoughts with us said they thought it was a good program, that was well-intentioned, that there really needs to be much more comprehensive therapy provided in addition to the medication, that they don't see as being abundant or available in the amount, in the way they feel it should be. One person described the MAT program as basically a pill line, but who thought it could really work if there was much more therapeutic measures brought in addition to just the medication. The folks in the field really did want to stress that they really believe there needs to be much better coordination between corrections and the community partners, that some of the obstacles that they see is the lack of communication or lack of coordination. Insurance issues, as you heard from testimony earlier today, present a challenge to them, and really lining up the timing with the release of an inmate and also the services provided by a pharmacy or provided out in the community. I think one of the other things that they really wanted me to offer to you about the program is the program does work if the inmate really has bought in, and if they really do agree that they really want the program. And there has been an effort to make sure that the services are arranged for them when they arrive in the community. So that was really a big theme that they shared with us, that they felt that there needed to be much better coordination from the time someone leaves the facility and goes into the community, maybe going under supervision. They really felt that was something that was seriously lacking. So those are the thoughts that I was asked to share with you, and I'm happy to take any questions that you may have about that.
So thank you, Steve. It's been very helpful. And I have a question in terms of if a line staff person is seeing the diversion occurring, someone's on MAT and they're seeing the diversion occurring, does that correctional officer go to directly to the medical staff from WellPath to indicate that they're seeing diversion? Or does that correctional officer go to a supervisor? And also, it was testified earlier today from WellPath that before someone who's on MAT is taken off MAT or continued if there's diversion. There's a team that comes together to review the situation and the person's medical situation as well as security situation. And would that correctional officer be part of that team? Or is there someone else? Or how is that working? So I guess it's twofold.
Yeah, so those are very good questions, and I'm not trying to duck them, but I am going to direct you to the Department of Corrections to answer that question, because I actually don't know the answers, but I'm sure that somebody in corrections knows both what the expectation is in practice and also whether there is involvement in that review team. I don't know the answer to that.
So you haven't heard from the folks you represent that they actually participate or don't participate in that decision-making process, correct?
Yeah, I have not heard from them about that they are. I don't know if they participate in that. No one said to me that they did. But generally, their feeling is that the program, in its establishment and in its growth, really that they felt they were not adequately consulted or not adequately consulted about the operation of the program. These are from folks who, that's not to say that there's no correctional officer that's ever asked, is that generally the folks who reached out to us said that that's how they felt.
Yeah. So Senator Sears has a question, Dick?
Well, actually, yeah, it's both a question and a comment, but it seems to me during the earlier discussions, there's a number of different groups that make up the population of offenders inside of our prisons and outside as well. But honing in on the detention population, which I think is about 450 of those who are incarcerated right now. I don't have the daily count with me. I'm curious to know how much of a challenge that is, both for the corrections officers as well as trying to coordinate any kind of release that is in the best interest of that offender. So I realize there's a certain population that's held without bail that are probably going to be there for a year, but they still haven't been convicted of a crime or of the latest crime. So I'm curious about if, you may want to check back with the members, how much of a problem that is for them in terms of the security, as well as, there is another role of corrections, and that is the rehabilitation. And most of the security staff that I've spoken to are adept at both roles. And many times are the only people that many of these offenders trust. So I'm wondering if you either can check back or if you have any comments on that particular population and how much difficulty that is. I've long been a proponent, as you may know, of if we're going to build new facility, that the new facility should be just for detention.
Yes, Senator. So I will definitely check back with our members. They did not discuss with me the particulars around the detainee population. Generally, the biggest concern, and you've heard it from me for years now, is that there is not enough staff, and they feel that there is an impact across the entire facility and system when you have a program which they describe as massively labor intensive. When you don't have enough staff resources. So that's really one of their major concerns. I will ask them particularly about the detainee population and get back to you with that.
That would be helpful as we begin to look at the population and so forth. I just growing concern about that, particularly the challenges they face. But I'm also concerned, your comments about working with the corrections folks in the field as somebody is being released, and the difficulty in coordinating that as well. I hope that the Senate Judiciary Committee and the Senate Corrections and Institutions Committee have an opportunity to at least sit down with all of you this session, and talk more about those difficulties of the transition. I was talking with Senator Harrison from Windham County, and she's been talking with some of the officers in the field, and particularly in Windham and Windsor County, there being a lot of time is spent at the hospitals.
Yeah.
That's not spent in the community.
Right. I think the pressure from the hospital program in those particular communities in the South is pronounced because of the population at Springfield, the particular characteristics of the population at Springfield, and it has had an impact on their ability to do the job that they really want to do in the community. So I will. I'm sure they would be happy to talk with you about that, and I'm very happy to arrange that.
That'd be good. Thank you.
Questions, Christine?
I have one. Steve, you talked about staffing issues. Like, when you refer to there's not enough staff, you're talking about the current staffing issues or lack thereof? Because in the conversation I've had is that has increased dramatically and is improving greatly. So when you're talking about staffing issues, are you saying that if they're at full staff right now, that's not enough staff? And if so, what is the per capita, like so many detainees per so many staff throughout? Do other states have maybe the commissioner can answer that question. I'm not quite sure, but.
So I think it's a good question. I think when this program began, our members were very skeptical because of the amount of labor, the intensity of the program and the labor requirements on the ground, and what they felt was a disconnect between good policy where it meets reality. It's gotten better since the start of the program. When we began the program, there were times when the union had to intervene to get our staff bathroom breaks because nobody was coming to relieve them on their posts. They were on the med line. So that has gotten somewhat better since then. But the staffing crisis still exists in the system, and Senator Sears just relayed part of an example of that. We're still relying on field staff to take a major role in covering for the lack of facility staff by doing hospital coverage, which is pretty intense. So all of that has an impact. I think that this frustration is when you have something that is as labor intensive and you impose it on a system without hiring additional staff to administer it, it creates a bit of a backlash throughout the system and a disconnect between those in the facilities and those who may be planning it in Waterbury.
But you hear the commissioner respond to the staffing
Yes,
issues.
yeah. You want to respond, Commissioner?
No, thank you. It's a fascinating question. I imagine we'll spend a lot of time this session talking about staffing in the correction system. Steve's right to point out that the MAT program is extraordinarily labor intensive. A lot of staff hours go into facilitating the program. Now we're 5-ish years into the program. I think we've worked out a lot of the kinks, and it has become part of the daily business of corrections in the state of Vermont. That doesn't mean it's running perfectly, and certainly there's room for improvement. On the broader topic of staffing, Steve and I have spent a lot of time talking about the staffing crisis in the state of Vermont. In July of 2022, we had over a 30% vacancy rate in our security staff positions. Today, the department's overall vacancy rate is under 15%. The staffing rate in our facilities is just over 16%. And so we've made precipitous changes in the way we're staffing our facilities. We've transitioned our shift schedules. We've made major investments in staff, both monetary and also in career development, in wellness, really trying to wrap around all the different ways that we can recruit and then retain high quality, high caliber staff. And those efforts appear to be working and working quite well. Also pleased to hear that Steve raised the issue of hospital coverage. That was one of the primary pain points that our field was experiencing. They were covering hospital shifts. We were able to design and launch a team that is specifically charged with managing hospital coverage across the state. That didn't eliminate all hospital coverage needs either by a facility or some field offices, but it completely changed the landscape. And so that team has been up and running since about Thanksgiving, just before Thanksgiving, and we're seeing really impressive success rates. And so one of the things we want to do when the session starts is come in and explain how that team is working and how many shifts we have eliminated from the field just in the short time that it's been running. And we hope through that team, as well as volunteers, that we can largely cover all of the hospital needs across the state going forward. And so we'll look to continue to build and improve that team so that we can totally eliminate it. But I think what you're hearing from the field is totally different today than it was even 6 weeks ago.
Anything else for folks? If not, thank you, Steve. I'm sure
Thank you.
I'm sure we'll see you in a few weeks during the session.
You will. And I would also like to just say before I leave, how much I'm going to miss Peggy. She has been incredibly helpful to us and has been extremely responsive whenever we needed anything. So I just want to say thank you and wish her well.
Thank you, Steve.
Thank you. One thing too, before we finish up with this topic, one thing I want DOC to do, and for us, for when the session starts, we went through a little bit of the cost of MAT within our facilities, and it's based on pill itself. If we went to the strip medication, the strip, what would be the cost of that versus what we're doing now? And also, I think when you incorporate that, you have to incorporate staff time as well as the time for WellPAP. Because right now, it's really labor intensive for the pill version. It's also a different makeup of this. And if we went to the strip, it might help folks as they re-enter because they will be starting up on the strip version when they re-enter into the. And it's a little different formula than what they're receiving in corrections right now.
That's right. Yeah, so we've got cost estimates. We have the cost actuals for the program now, and then we can bring cost estimates for a change in the medication.
So that would be helpful to see if that's some direction that we want to pursue legislatively and budget-wise.
Yeah.
For that. Anything else?
If I just might comment, the commissioner's first comments, I think, really show us why we need to, and hopefully the health and welfare and the committees in the House will take a good hard look at this. But if 60% of the DOC population have a substance misuse disorder, certainly it's certainly is a huge problem. And he said that didn't include other who have substance abuse issues. So I think we have to keep that in mind throughout. I thought that was probably the testimony that struck me the most, is that particular factoid. And I think, I don't know if that's 61% or 59%, but I would like to have a more clearer picture in January of exactly the problems that your population faces, because that explains a lot of the WellPath problems, a lot of the problems that we have with security and et cetera. So I think I want to not lose sight of the first comment.
I think that also plays into the issues of reentry, because they're all different levels.
Yeah. Oh, yeah.
Teresa?
I just wanted to comment on what Senator Sear said. I think that is probably one of the most telling pieces of information. And how do we think about, and whether we think about, and what Steve was saying earlier, incarceration is not a treatment facility. And yet that's kind of exactly what we're asking people to do, and if we have that large a proportion of individuals who have those challenges, then, what is it that we need to change about our correctional system in order to be able to deal with that while we're still trying to deal on the outside with, prevention and, changing things, so people don't end up there with that issue. Because I think that, I think we need to be more cognizant here that, essentially we're asking corrections to be a treatment facility, and MAT is not the only part of substance use treatment. And, I just think that whole thing, I'm sure our institutions, corrections committees will take a deeper dive into that, because that, I think is really getting at sort of the root of some of these issues that we're talking about, both from a staffing perspective as well as from an individual, incarcerated individual perspective in that transition back to the community, as well as their time in incarceration. So I think I don't have any answers to that, but it's a significant challenge when you've been asked to do essentially two major jobs, become a treatment facility as well as a security facility.
Can I add just one bit of context? I mean, Senator Sears, I couldn't agree with you more. That statistic is very scary to me as a Vermonter, as the Commissioner of Corrections. It's also worth remembering that nearly no one in our prison system is there because of drug charges. So they're not there because they've been charged for something related to opioids, though their probably attendant actions got them there. They're there for other types of crimes. And so we have a population who's incarcerated for a variety of different charges, and they're not drug charges, and they still, 60% of the population has an opioid use disorder. That is really troubling too.
You're right, but it also reminds us that when we treat folks for medical conditions, this is one of them.
Mm-hmm.
And it's rampant. So we need to ensure that whoever we have, WellPath or other, or public support, is treating the underlying condition. And it's not twice, it's 30 times as more difficult when it's in an institution, a corrections institution. So, yeah, we've got a lot of work to do together to ensure that folks are cared for medically, cared for with counseling, and then cared for within corrections. And then, we could go on and on about what kind of correctional facility would be the best one for folks today, but we won't go there. But this is going to be this is a big conversation for all of us going forward.
Yeah.
Also, I appreciate what Representative Wood put out there in terms of the lens as we look at DOC. Because I know the legislature is being asked this next time around from our constituents and the public to get tougher on crime, get tougher on repeat offenders, get tougher on burglaries and theft. And ultimately, I think folks in the public want to see folks incarcerated. And I think that's the balance that we're going to have to look at, that's going to put more pressure on DOC, more pressure on, do you provide security or do you provide treatment? And the more folks we bring into our incarcerative settings, for right or wrong, I'm not judging either way, but it's going to put pressure on DOC to provide more services. And then we as a legislative body need to come up to the plate and fund the department appropriately to be able to provide that with staffing numbers that are needed, with healthcare, mental health, as well as space.
And I just have to say that we're not doing that yet for people who are not incarcerated.
Right.
So I'm just, making, not making a value judgment, everybody should have access to appropriate healthcare, but, you know, no.
So I'm just getting a notice here from our legal counsel.
What we have.
If we have any recommendations to make, you don't need to, it might be a little premature, but do we have any recommendation for any legislative action that would be, that we want to see to ensure continuity of treatment?
You're thinking about what's in Act
Yeah,
22? Yeah.
Act 22. It's H.
H20.
Before we, I think before we can make recommendations, I think we all need to better understand the population we're talking about and what it is we could do more than what we're doing. So I'm a little worried about that. I think our recommendation at the last meeting to ask the Health and Welfare and Healthcare and Human Services committees in the House to take a hard look at corrections healthcare. Maybe we want to expand that to, or make sure that the MAT treatment is included in that. But I think one of the things that would be extremely helpful would be the waiver that we talked about earlier that California's got and that the commissioner spoke about. I think that would be an important step forward. If you had the waiver, you could do it much more seamlessly, the reentry piece. Because my understanding is that the highest group of overdose deaths come about from nationwide, those who have been incarcerated and within 8 weeks of their leaving the facility.
So I'm wondering if Betty would like to see that as a ask to add on to the memo that we sent to the standing committees in the Senate. It was Health and Welfare, I'm assuming Judiciary. In the House, it was Healthcare, Human Services, and Corrections and Institutions that had memo that was like 2 months ago. If we added this, that while they're looking at providing healthcare services in our facilities, that it would include the MAT program, include the continuity in terms of reentry for folks who are incarcerated, and also looking in at the waiver. If we added that to the memo, and if that could just be distributed to us to sign off maybe the first week of the session.
So so in looking at the Section 8 of the Act or the bill.
Act 22, yeah.
Yeah. I think what you're saying is first, because that's what we've been asked to look at. The transition, the discharge based on population, probably important. And then the second level is healthcare overall, which would go to Human Services, House Healthcare, and Senate Health Welfare, as well as
Corrections and institutions.
Right.
So it adds on to the memo that we.
Yeah, no, I think it's a great idea.
So with the committee
Just
members.
adds more work.
Well, it kind of helps Ben a little bit, but he doesn't have to do it in a week. We got 3 weeks.
We'll take 2.
Oh, we have all of 18 weeks, Senator.
Right, but maybe we could do that, just distribute it to the members electronically the first week of the session, and we're back. And we're gonna Yes, we do. Yeah, we're 2 years. Yeah, we're back next year.
Yeah.
This is only the middle of the budget.
That's already in 2025.
We're here for the long.
Looking ahead.
So just to clarify, so the things you want to add to the letter include.
Discharge and reentry.
Based on population, prison population.
I think we should avoid referring back to the committee, the exact thing that the committee referred to this committee. Okay, so I'm just saying, that language will be doing that. So one of the things that we learned here is about the potential for a waiver. And so I think maybe from, my committee landed this here. So from my perspective, I think that further investigation about the process, the timing, the things that maybe are holding us back, when we might, think about doing that. So I guess I would be a little more specific in the letter saying that, or the memo saying to investigate the waiver, because our committee was most concerned about the transition process, and that seems to be the biggest quote unquote action step that we could maybe affect some progress in. So that's just my feedback.
No, that's helpful. That's helpful.
But
I agree with that.
by prisoner type, by per individual type, so that makes
Detainee
it
versus
detainee.
sentence.
Right, we
Right.
learned that they're very different.
The waiver would apply to both, which is good.
Yeah.
Right.
It
We
has,
have a whole different process. I mean,
Right,
that was
right.
very helpful
That's
for you to sort of illuminate that, because somebody who you're gonna have for 48 hours or, whatever, 4 days
Different
is
than a year.
very different than, and I think we need to sort of recognize that.
Just to clarify, are we recommending pursuit of the waiver? Or just looking at it more?
evaluating it.
Evaluating it?
If we're gonna
Pursuing
say,
it.
I would like to pursue.
well, we can pursue it, but I think the committee's gonna have to hear from Diva.
Mhm.
They're gonna, what are the implications for state funding and state match? There are some questions to be answered about,
And the IT system.
among other things.
I can say Diva is actively pursuing it. They're actually meeting right now this morning.
Good, so we'll hear back from Diva on that one. Good.
So are we gonna evaluate or pursue, or do an evaluation and then pursue based on the evaluation?
Let's look at the letter that Ben comes up with.
Keep it action oriented.
Mhm.
Okay,
You
so
wanna
the
add-
two areas, so you explore the discharge planning, reentry based on detainees as compared to incarcerated individuals. And then to evaluate, pursue, I'll figure some word out, the waiver, from the Medicare exclusion and Medicaid, excuse me, Medicaid exclusion, to include the process, the timing and other considerations.
So flip that in terms of waivers, our first recommendation. That makes sense.
How can we get at, looking at what, I mean, we've asked to look at the discharge process. So I think we need to understand what the discharge process, what the guidelines are. But how can we ask the committees to invite the departments in to hear what that is, so we can make recommendations about any necessary whatever's,
Our recommendation is we need to do more work.
right?
Or that, figure out how to do it.
We've heard staffing
Mhm.
issues, and I think I mentioned early on, counseling, mental health needs. So there's a lot that we've heard that could be embedded in that letter.
So Ben, work your magic.
I'll do my best.
And then you can send a draft or send it to us.
Yes.
Okay.
Yeah.
Well,
That's good. I don't want to go.
Can I ask a question, just since this is our last meeting? Has corrections been actively recommending a separation of the detention population and the fully prison population?
No, I mean, ultimately, it's the practicality of that in our current.
Where are you gonna put 'em?
The structure is nearly impossible.
Where are you gonna put them? You gotta have.
I'd be happy to discuss that.
Yeah, I didn't know if looking ahead at new infrastructure, that was your recommendation.
I mean, ultimately, the only new infrastructure on the horizon is a new women's facility.
Mhm.
And the plan of that facility right now is not to separate by detention type, but to separate folks who might qualify for a reentry facility, a less secure, more community-based facility, and a secure facility. But not by a detention type, although that is implicated in who would qualify for what.
The issue when you look at that is, do you do a centrally located building? With all the detainees, you need a building, put them somewhere.
That
And
that
then-
was a recommendation of the Hogan Commission.
Way back. And
Way
then
back.
then the question becomes, who does the transports? and you could do video arraignments, but then when the person's released, there's the center of the state, they have to go to Bennington, or they have to go up to Newport or down to Brattleboro. How do they get there? And then when a person is arrested and charged, and then your local law enforcement has to drive an hour to drop them off at a central facility. Those are some of the logistics that would have to be worked out, and you got to find a building that would be large enough to hold them in a community that would be willing to site the building. So those are kind of the layers.
Yeah, just so we can talk, I mean, I think it's worth coming in this year and talking to you all about why do we have them together? How does that work in practice, and what are the drawbacks and benefits of that? Because there are both.
Yeah.
And at the end of the day, this all comes back to the size of it's very challenging to create economies of scale. And then we have kind of an aging infrastructure that is difficult.
So we need to move on. We're running about 20 minutes late, but this has been very helpful. Any further thoughts, questions? Thank you, Commissioner. And you'll be back. I want to transition a little. We're scheduled at 11:30 to go through a report on the Community Violence Prevention Program with the Deputy Commissioner of the Department of Health. And Act 23 established this program, which is administered by the Department of Health, along with consulting with the Department of Public Safety, the Chief Prevention Officer, the Director of Violence Prevention, the Executive Director of Racial Equity, and the Council for Equitable Youth Justice. And the program, this is by what's in Act 23, the program would permit Vermont municipalities and nonprofit organizations to apply for grants to fund innovative, evidence-based, and evidence-informed approaches to reducing violence and associated community harm. So, Deputy Commissioner Dougherty, we would just like an update and what communities are participating, what nonprofits are participating, and how the program is being.
Sure. Again, for the record, my name is Kelly Dougherty. I'm Deputy Commissioner at the Department of Health. And I'm happy to give an update on this program. So we did issue an RFP to communities to apply for grants. That was put out on October 16th, and the RFP closed on December 1st. There were 32 applications that were submitted, and they were for a wide variety of topics, including illegal drug activity, gang activity, human trafficking, domestic and sexual violence, and a very diverse application pool. The applications are currently being scored by a committee with pretty diverse representation. They are actually meeting this Thursday to review their scoring. And then they will be identifying who will be getting the awards. So the program intends to fund up to 15 organizations for 3 years, not to exceed $150,000 per year per program. We're going to be issuing 2-year grants for these programs. The total amount that was requested through the RFP process was over $9 million. That was reflecting 2-year budgets that were submitted. Obviously, we're not going to be able to fund every application. But like I said, the group is meeting this week, and awardees will be informed by next Wednesday about the status of their application, and the grants will start on February 1st. As you recall, we were allowed to use 5% of the appropriation to hire a program specialist to manage this program. So we did hire someone who started on November 20th. So their job will be to be monitoring and providing technical assistance to the grantees, and ensuring that they are submitting the appropriate reports and also looking at promoting violence prevention best practices, to our community partners. So it is moving forward, and we should be able to let you know who the successful bidders were very soon.
Okay. Senator Sears first, and then we'll go to you, Keisha.
Deputy Commissioner, I really appreciate the update. One of the pieces of legislative intent was that any federal money that might come down from the community, I can't remember the name of the federal program, but it was similar to the grant, that could be included in that. So, I'm not suggesting that everyone be funded, but it may be additional money into that grant program beyond the 5 million in state dollars. And I'm not sure, where that grant money stands right now, the federal grant.
Right.
But I know that part of it was to help with so-called extreme risk protection order laws, and Vermont, I think, has a pretty good red flag law, and and for the implementation of that. And I'm wondering if that's been looked at as well in terms of these grants.
I am not aware of that grant, but I can certainly look into it.
It was passed as part of a federal a gun. I won't say gun, but I think it was violence prevention. But I'm not sure that that's
Safe Communities Act.
Bipartisan Safer Communities.
Safer Communities Act, is that what it was?
Yeah, that's what I'm thinking. Thank you.
Mm-hmm. Just to keep track of it. Keisha.
I just wanted to know your scoring rubric as we look at the outcomes of who was selected.
Yeah, so I don't have the rubric in front of me, but they did develop, when they developed the RFP, they did develop a scoring instrument for the grants, and I'd be happy to share that with you.
Thank you.
Martin?
Yeah, just follow up from what Senator Sears was asking. I guess I just want a little bit more than, I raised this with some other folks in administration months ago as far as the availability of federal grant money for community violence prevention programs. And at that time it was, we'll look into it. We don't know. And I'm hearing the same thing again today. And there's money out there, from what I understand, from the Safer Communities Act that really should be looked at, especially when we're seeing that it's a $9 million worth of request and we have $5 million set aside. I think it's pretty critical that does get looked into. So.
Yep, I certainly will do that. And I'll also check in with our partners over at the Department of Public Safety, because they may be moving on that.
And that is actually who I was talking to, somebody in the DPS, and I can't remember who it was, but.
And would there be a state match for some of them?
I don't know.
The pro tem is at the White House today on gun violence. So I can text our chief of staff who's going with him and just ask her to mention this.
Yes, good idea. Go right to the source.
But we're instant, yeah.
So Deputy Commissioner, is this also the program, I just want clarity here, the Community Violence Prevention Program, is that also what's being rolled out, or is it separate from what's being rolled out with former Commissioner Jim Baker in terms of looking at some communities to come together and talk about community safety and what initiatives come? Is this also part of this program? Is that part of it, or is it a little different?
It's not, it's separate,
Okay.
but we are connected to that. That's the what we call the PSET group. And now I'm going to blank on what that stands
It's
for.
a 10-step person.
Yeah. So we at the health department are involved in that work that former Commissioner Baker is doing, as well as a lot of other state departments and agencies. And we did, Dee Barbick is on that group with Jim Baker, and she's also part of the team on this. So there is a close connection, but it is separate.
Yes. Anything else on this before we take our lunch break? Thank you, Deputy Commissioner.
Thank you.
And you've been with us all morning. You can come back in the afternoon if you'd like.
Have a good rest of the day.
Yes, you too. So we're gonna, take lunch. We're gonna lunch. We'll be back at 1 o'clock, and we're gonna shift gears a little bit to raise the age and our juvenile justice, arena, and also our secure facility for juveniles involved in the justice system. And also later on, we're gonna hear from, certain folks who are interested in our out-of-state incarceration. Our inmates. And then we're gonna finally have our final conversation on home detention and review the letter. And then we're done for the year. So we'll